Good morning. Now, Mr. McIntosh, our first witness is Dr. Davidson.
Dr. Davidson, my lord, yes.
Good morning, Dr. Davidson. Please sit down. Now, as you appreciate, you're about to be asked questions by Mr. McIntosh, who's sitting opposite. But first, I understand you're prepared to take the oath.
Yes.
Sitting where you are, could I ask you to raise your right hand and repeat these words after me? I swear by Almighty God
I swear by Almighty God
that I will tell the truth,
I will tell the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you, Dr. Davidson. Now, I don't know how long your evidence will take. I anticipate it will certainly not take the morning and may take a little less. We will take a coffee break at 11:30, but if at any stage you want to take a break, just give me an indication and we will take a break. So feel that you're in control of the situation. Now, Mr. McIntosh.
Thank you, my lord.
Thank you.
Dr. Davidson, I wonder if I can take your full name.
Scott Mitchell Davidson.
Thank you. Now, you produced a statement in response to a questionnaire we produced, and before I ask you whether you adopt it as your evidence, I think you want to make a minor correction, which appears in response to question 23, which is on page 162 of the statement bundle.
Yes, it's simply, I put in I didn't attend and it should say that I did.
Thank you. So that's page 162. You did attend BICC and you did so as the chair of the acute
Yes.
infection control committee. Thank you. But we'll go back to that because we are going to touch on that committee later on. With that correction, are you willing to adopt your statement as part of your evidence?
Yes.
Thank you. Now conscious that you are currently, well, what's your current job title?
I'm the Executive Medical Director and Responsible Officer for NHS Greater Glasgow and Clyde.
Is there only one medical director in the health board?
You have one Executive Medical Director and I have a number of deputies, and you have one responsible officer.
Thank you. Now, what I want to do, because we're dealing with events that largely happened before you took up that post, is to walk through, not directly following the structure of the statement, the various jobs you've held,
Okay.
and ask you a series of questions as we go, which there'll be more questions as we get to the later jobs. If I might start looking at your statement on page 132, you helpfully provided the years you held various posts. And so I want to look at the period from 2015 to 2017 when you were Clinical Director of Medical Services. Now, before we look at that, when you're as a consultant respiratory physician, which wards would that be normally?
So when we moved into prior to moving into Queen Elizabeth, at the Southern General Hospital, I had one ward.
Yes.
And in the Queen Elizabeth University Hospital, we moved into a unit that had 4 wards, 112 beds, and also a front door receiving unit of 16 patients.
And are those wards mainly on the 7th floor?
We had the whole of the 7th floor.
7th floor.
Or we do have 7th floor.
Now, I have a memory, which you may want to correct me, that on one of the 4 wards on the 7th floor at one point contained the cystic fibrosis ward. Am I right in that?
Yes.
Is that part of your unit in essence?
So I'm not a specialist in cystic fibrosis, but yes, we have cystic fibrosis.
And that sits within the respiratory community, as it were?
Yes, they're part of the team.
Thank you. Now, if we think of the period 15 to 17, how many of I'm assuming you were full-time 10 sessions at this point?
So I was a 12-session consultant.
Right.
I specialise in home ventilation of neuromuscular patients. And I had 2 sessions a week for clinical director
and
role.
10 sessions for practice?
Yes, plus on call for weekends and overnight.
Now, we've been hearing evidence about various different bits of the hospital that may or may not have had at various times issues with their ventilation systems. I'm assuming that your responsibility at this point didn't cover any part of the children's hospital?
No.
No, or indeed the regional bone marrow treatment unit that was occasionally in Ward 4B, that wouldn't have been part of your responsibility?
No.
No. And would infectious diseases have come within your remit as clinical director, medical services?
Yes.
Yes. So I suppose the question is simply this. What knowledge did you have in this period when you were clinical director of medical services about questions of whether the general wards in the adult hospital had an air change rate somewhat half of what was recommended in national guidance?
I don't recall having any awareness.
Thank you. Now I want to move on to the period from the next period on your CV. So go back to your statement, the final paragraph, 2017 to 2019, Chief of Medicine, South Sector. Now, of course, you remained a consultant respiratory physician, but how many sessions were you, as it were, still doing a clinical practice at this point?
To begin with, I was employed on a 5-session managerial contract. I had a 12-session contract because I still did my on-call and still practiced clinically. And latterly, I think I was up to about 7 sessions in terms of managerial, perhaps 8.
So it started as 5 out of 12 and moved towards 7 or 8?
Yeah,
Right.
yes.
Again, would this only have included adult patients?
Yes, South Sector.
And would it have included the adult BMT ward?
No.
No, right. So again, to ask the same question again, when did you cease to be Chief of Medicine? What month was that?
So it's quite hard to answer because there was a bit of a changeover in terms of getting someone in and moving. So I kind of did probably a bit of both. I went on a holiday, I think it was June or July in 2019. And when I came back from holiday, I felt that I was totally into my
Right.
new role. At that
And
point.
Dr. Stewart explained he retired in June of 19.
Yes.
Yeah. So if we think of the period between your arrival as Chief of Medicine and that soft changeover, as it were, what knowledge did you have about the question of whether the general wards of the adult hospital had an air change rate of half or so of the national guidance?
Again, I don't recall an awareness of that.
Right. It's probably worth, before we go on any further, asking, when did you become aware of that issue?
I need to refer to my statement again, if I will, because I want to get it absolutely
Of course,
right.
yes.
But, sorry, it was certainly, I was aware, obviously, of the need to decant children, but in terms of air changes, it would have been in my role as Deputy Medical Director.
Right, so you actually mentioned that on page
Yeah.
149. So it's, if you go to 149 of your statement,
Yes.
so you became aware of this issue. You say the decant, you were aware of the issue when you were Chief of Medicine South Sector. In terms of the ventilation, you think it was when you were Deputy Medical Director that you learned about the ventilation issue?
Yes.
Thank you. Let's go back to your statement now and go to page 137, because you mention a group called the South Sector Management Team. And that's an answer to question 6. And what I just might help us to connect you to other people in the story. When you sat on the South Sector Management Team as Chief of Medicine South Sector, who was the general manager of this? I understand there's 3 of you in a management for a sector. There's you and a nurse and a manager.
As the Chief of Medicine, I sat with the Director, Anne Harkness.
And who was the chief nurse for this particular sector? Can you remember?
Sorry, I can't remember.
I understand. Now, you actually provided a copy of the South Sector Clinical Governance Annual Report with your statement, which we'll put on the screen for 2017-2018. That's Bundle 52, Volume 2, Document 32, page 426. And if we go to page, can you explain what the purpose of this report was and who was the audience it was to be read by?
So we would always we would pull together a clinical governance annual report for the team within the South sector. We were still a very early team, having come together in 2015. And so we tried to pull together these reports that demonstrated the work that was being done within the team across the sector. And then obviously you would share that within the team in the South sector.
So go get people in the team.
Yeah.
Would it go up the system as well?
I can't actually recall if it did.
Right. The reason I put it on the screen is because there's nothing in this report, no reference to any suggestion that to this issue of ventilation. And so presumably that would be consistent with what you just said, but 17, 18, there's no mention of it in there. Right. Now, I want to pick up your membership of AICC. And I'll put it to you in short and see if you'll accept it. And if not, we can go and look at the document. There's a minute from the 19th of June 2018 describing you being appointed to AICC. And for background, that's bundle 13. I don't need to put it on screen. Document 16, page 121. But you don't actually attend meetings of the AICC until you become Deputy Medical Director. Is that what you recollect to be the case?
Yeah, so I've read through them, and there's certainly, I think, 4 or 5 where I was unable to attend. My apologies.
Can you help us about why that might have been?
It will almost undoubtedly have been clinical commitments.
And the pressures of clinical practice.
And the pressures of clinical practice.
Now, we went and looked at your statement, and I took you to a paragraph slightly out of sequence. It's page 149 of the statement bundle. And this is about the decant. Now, if we look at page 149, we asked you a series of questions and you put them into the form of a table. And so you seem to be saying that as Chief of Medicine, South Sector, you were aware of the need to decant 2A from the Children's Hospital to 6A in the Tower.
Yes.
Can you help me about why you would have been learnt that, what your involvement in the decant process would have been as Chief of Medicine, South Sector?
Mainly that the move was going into one of our adult wards.
I understand it was a care of the elderly ward. Might that be the case? Or?
I'm not sure it was care of the elderly. I think it was split, and I think some of the renal team worked in it as well. I can't recall. But it was a general medical ward.
Did you have any particular involvement in this process, or was it just something you were aware of and sort of been handed to you? You're losing the ward, or were you involved in the debate in any significant way?
I don't remember any significant debate.
However, you become Deputy Medical Director, Acute Services, and we understand of his Dr. Stewart's retirement in June 19. You just explained about going on holiday, coming back in the autumn. You're in the role. Can I just understand from your perspective, how does your role relate to that of Dr. Deegan as Deputy Medical Director Corporate? What's the sort of split between the two of you?
So I was, the acute role was, I think, much more operational in terms of what was happening on the ground. And Dr. Deegan's role was more corporate and probably looking at policies and such like. So we were quite different roles, and the acute medical director, or the acute deputy medical director, sorry, I think was a new role when Dr. Stewart retired, so they were split. So
because previously he'd done both, effectively.
Yes.
Yes. And is the general manager at this point who you're working with, Mr. Best, as Chief Operating Officer for Acute Services?
Yes.
Right. Now, I want to just deal with your attendance at BICC and NIT, and the reason I'm just going to do this is I'm going to come back to some questions about it later. You first attend 29th of July 2019, that's bundle 13, document 58, page 425. Now, by this point, I think you might have attended one meeting of the Schahalian unit IMTs earlier in the year. Does that roughly accord with your recollection?
Yes.
Yeah. So this is your first meeting, and if we step through onto the next page and the next page, we will eventually see, keep going, next page, next page. We see item G on page 430, a short note of a report on water and ventilations at the Queen Elizabeth. Now, the reason I'm putting that on the screen is just to ask you, at this point, can you sort of summarize what you understood the issues around water and ventilation issues were? This is July 19 in the Queen Elizabeth and the Children's Hospital.
As I recall, we were seeing some children with gram-negative infections, and therefore beginning to work through that.
Do you have a recollection of knowing at the time, in a sense, when this story had started? I mean, you might not have known about it at the start, but you might have been told about when the issue of gram-negative infections might be said to have begun, in some sense, in the Children's Hospital.
I couldn't put a month on it, but it would have been through 2019.
Right. If we go to the next meeting, the 7th of October, that's the same bundle, 13, document 59, page 433. We see Dr. Armstrong's in the chair and you're present. And again, if we step forward to find the equivalent item, so we go forward, forward. Now it's here. It's on page 453. It's the 5th bullet point. There's a long record of a discussion. Now, the question I had for you at this point is, various events have occurred in the period since the 29th of July. And I wondered if you can help me the extent to which you had been told about any of these things by the time we get to October. And so the first one would be you obviously knew about the involvement of the Scottish Government because it's mentioned in the minute here, so I didn't ask you about that. The second one would be the resignation of the lead infection control doctor. Do you remember when you were told about that?
It would have been after my leave in 2019.
Right. So you went away on the leave in the summer.
Yes.
I mean, I'm at risk of asking how long your holiday was. Can you remember roughly when you came back?
I was away for 2 weeks, but I can't.
Because the date of the resignation is early in September, and I'm wondering, it's only a few weeks before this October BICC, and I wondered how if you learnt about it before the meeting.
I don't recall when I knew about it.
Did you learn about it at some point?
Yes.
Yes. Can you recollect what you were told about the resignation of the lead ICD in that autumn?
No.
One of the ways that some people have described the period between July and October, I suppose, with various bits of evidence over the last year, but it includes, from many people, a session of tension within the IPC microbiological community. What awareness did you have by the time we get to October, so it's 2-3 months after your holiday, of such a tension?
I was aware of tensions.
What would have been your source of briefing on that?
So I think having attended, I'd been at IMTs and just general discussion.
There was no formal briefing to you of what was going on?
I don't recall having a formal briefing.
Now, I've already asked you about when you learnt about the issues around the ventilation in the general wards. I wonder if I can now press you on a couple of other issues that we're aware of. So the first one is, whether there were any standard operating procedures or ways of operating in the infectious diseases unit which addressed the absence of isolation rooms in wards 5C and 5D at this point.
I wasn't aware of any particular SOPs.
Did you ever become aware of an issue around sometimes patients were to be sent to other hospitals if they had certain conditions? Are you aware of anything around
So I
that?
was aware that there was the rebalancing of the rooms in the 5th floor, and obviously there was then work done within the critical care floor of the Queen Elizabeth with regards negative pressure rooms. So I was aware of that one.
And when it was done?
I was aware of it at the time, yes.
Yes. And that picked up one of the other issues. The final issue relates to the ventilation system in Ward 2A. Now, obviously, Ward 2A is being closed, and there have been reports prepared by, amongst others, innovative design solutions about the ventilation in 2A in the latter part of 18. I wonder when you became aware of the program to upgrade the ventilation in Ward 2A.
I couldn't recall when I was aware of it, but I was certainly aware of the work and being planned.
Is this around the time being Deputy Medical Director?
Yes.
So if I put to you that effectively, prior to becoming Deputy Medical Director, you would have had no knowledge about any issues with the ventilation systems in the Queen Elizabeth, would you accept that?
Yes, I don't recall any other detail.
Thank you. Now, given that you were in both the respiratory consultant
Yep.
and then Chief of Medicine South Sector, do you think you ought to have been told about the fact that the general wards had a low air change rate compared to Scottish Government Technical Memorandum guidance before you became Medical Director?
I don't know the answer to that. I mean, I think I moved from working in hospitals with Nightingale wards, and I was moving into hospital with single rooms and en suites for every patient. So that was seen to me as a real bonus. So I have to say I had no concept of what a low air change rate would even mean.
I suppose one of the differences between a Nightingale ward, in addition to that,
Sorry, just for my note, no concept of,
The low air change and what that would mean.
right, no concept of what a low air change
Yeah.
rate would mean. Thank you.
I suppose the Nightingale ward, not only would it not have single rooms, but it would also have opening windows. I'm presuming the Southern General, you open the windows if it was a bit stuffy.
In the main.
In the main, yes. If you think about the 7th floor and your time in clinical practice as opposed to a manager, presumably you can open the windows on the 7th floor.
Nope.
No. Was there any ever discussion amongst you and your colleagues, and indeed with patients, about, in a sense, the air environment? We're sitting in a room here in this hearing center, which has 10 air changes. And you go into a room that has a low air change rate, you might perceive it to be different. Was there any discussion amongst your teams about the air quality on the 7th floor?
I certainly don't recall any. I mean, certainly you would sometimes be warm in the wards, but I don't recall any specific conversation.
Thank you. Now, I want to move on to your statement to the same page, actually, 149, where you touch on the risk assessment for Ward 4C. And this is the bottom of the page. Now, this is partly, I'm asking about this because I neglected to mention this in answer, putting a question to a witness last week. So there was a risk assessment done on Ward 4C.
Yep.
Now, firstly, let's work out when it was done, because we should look at the document, which is Bundle 20, Document 62, page 1428. Now, was this produced when you were Deputy Medical Director?
Yes, I think this is, I can't recall the date at the end of it, but I'm
If
sure.
we can step on, we can go and look at the end.
I think it was 2020.
One more page. It goes on a bit. There's some tables. Keep going. There we are.
Yeah.
February 2020.
Yeah.
Now, am I right in thinking that the people in the box were the people who actually did the work?
Yes.
Right. And can you help me understand, in a sense, why they were each involved, from their what they bring to the process?
Yes, of course.
Please, just start with the top and take your way down the list and explain from your perspective as medical director why they were involved in this risk assessment.
So the patients within the unit, particularly the hematology patients. So we had Mike Leach, who's the clinical director at that time.
And he's the clinical director for regional services or for South Sector? This is 4B after all, 4C, so it would be South Sector.
Hematology. So we had hematology patients within the Beatson as well as within the South Sector, but he would be regional, yes.
He's regional, right? Okay. And then we have Dr. Hart.
We had Alistair, consultant hematologist, again, as a consultant within 4C. Brian Jones as head of microbiology. We had Melanie McColgan, who was the general manager of regional services.
And effectively, is she the managerial equivalent of Dr. Leach?
Yes.
Yes.
We had Myra Campbell, who would be the clinical services manager. Daryl, who was there in terms of ventilation. Tom.
Would AP mean authorised person?
Pass.
Ah, okay.
Tom Steele as Director of Estates and John Green as our interim health and safety lead, and they will have undertaken the work related to the risk assessment.
Now, if we go back to the start of the risk assessment, page 1428, I'm going to ask you a series of questions, and it may be you don't know the answer, but I'd be interested to see what you do. Now, obviously, one of the issues that we have discussed in this inquiry at considerable length is the Scottish Health Technical Memorandum. Now, it 0301 that deals with ventilation systems. Is that a document you've now become aware of, but you weren't previously aware of?
I now know of is SHTM 0301.
Yes. Is there anything that we should take from the fact that it's not mentioned in the bottom right-hand corner as guidance to be referred to? If we look in the box, specific risk assessments or guidance to be referred to, it mentions the NICE guidelines, IDSA, ESC, MID, and infection rates report over the page. And then there's nothing else in that column. So it's not listed as a background document to this risk assessment. Is there any reason for that?
I would be surmising.
Now, if we go back to the list of people on the last page, it occurs to me, well, let me ask you the next question and then we'll work out who I should ask if I really need to press this. In your reading of SHTM 0301, did you come across the concept in one of the tables of a neutropenic ward?
So I have not read SHTM 0301 in detail.
But is it a phrase you've heard of?
Yes.
Yes. So I'm taking it you're probably not the right person to ask why there's no reference discussion of this ward being a neutropenic ward in the risk assessment.
No.
No, but if I want to know, because I failed to ask before, who on that list do you think would be the best person to ask? I'm suggesting probably Mr. Connor about why there's no reference to SHTM 0301 or whether this is a neutropenic ward in terms of that guidance. Can you help me about who are other candidates I might pick if I was going to send a brief questionnaire to?
I think Alistair, as well as the clinical lead.
Oh, in that case, we'll do that. So we'll contact Dr. Hart and Mr. Connor. Thank you. Take that off the screen, please. Now, Now, this is a question that arose from the evidence of both our inquiry expert, Mr. Poplet, and Mr. Calderwood, the former chief executive, up until 2015. It relates to the cleaning of chilled beams. Now, can I take it you're familiar with what a chilled beam is?
Yes.
When you arrived in the hospital, did you know there were chilled beams? Or what a chilled beam was?
No.
Because presumably you didn't have them in the Southern General.
No.
No. Can you remember when you first became aware of that there was such a thing as a chilled beam and there was one in each room?
I couldn't tell you when I first became aware of chill beams.
So, Mr. Poplet, who is an authorizing engineer, ventilation and inquiry expert, carried out an audit of the management of the ventilation system. Is that something you're aware of?
Yeah.
Yeah. And in evidence, he explained something he put in his report that I didn't understand. And he described that there's a challenging aspect of chill beams. This is column 118 of his transcript for my colleagues. They're challenging to clean because it requires patients to be moved out of a room whilst the chill beam is serviced or cleaned. And you have to deploy something called a HEPA cart, which providing a HEPA filtered airflow in an enclosure underneath the chill beam. And you put a cleaning member of staff, engineer, and a ladder inside the HEPA cart's enclosure. You clean the chill beam, and then you remove the whole thing from the room. And Mr. Calderwood described in his evidence, albeit this will be before 2017, how he recollected that the cleaning of chill beams caused an issue in that it delayed the transition from one patient to the next, because often you had to have a full clean of the chill beam when one patient had left the room before the next one went in. And I just wondered, as Executive Medical Director, whether this is an issue that you've come across in terms of delivering, well, effectively, bed occupancy and capacity in the hospital.
We have many issues with bed occupancy in our hospitals, particularly at the moment. I'm not aware of any issue coming to me because of chill beam cleaning.
Thank you. Now, the next topic I want to turn to is your interaction with the Oversight Board. So you arrived as Medical Director, Executive Medical Director in July, August, September period of 2019, and the Oversight Board arrived 2 months after you. I'm assuming it's been quite a high level of work since then. As Deputy Medical Director, having the Oversight Board around.
Yes, although I think we went into escalation in 22nd of November. Shortly after that, we had COVID, and the majority of my time was...
Because you went back to a lot of respiratory work, presumably.
I did a lot of work around the response to COVID. Probably one of the biggest things that I struggle with is the fact that I was not able to be as clinical as I would have wanted to have been during COVID. And during that time, I went in evenings and weekends to help.
And indeed, all hospital doctors worked exceptionally hard. We have a particular question that I've been asked to ask you about an interaction you had with a member of the Oversight Board, and that's Dr. Andrew Murray.
Yep.
Now, he provided a statement, which is from the Glasgow 2 statement bundles, and the section I want to turn to is page 525 of that statement bundle. Sorry, 529, my mistake. So earlier in his statement, Dr. Murray has explained that he was asked to look at the issue around the prescription of prophylaxis and whether it was being done consistently. I understand that was his task. Do you recollect that?
Yes.
Thank you. But he explains, paragraph 25, following my appointment, I spoke to Dr. Armstrong, and he set you up with a meeting. A meeting was set up with you. You can see in the second half, paragraph 25, and you had a conversation. He then goes to meet the hospital staff, and he gets various minutes and documents. And at paragraph 27, he describes how you helped him to understand the clinical context.
Yep.
And he explained the infection control position, explained the microbiology position, different specialties, also infectious diseases. Please go back to previous page. There were different players with the clinicians involved. I found there have been some tensions within those different clinical perspectives. I was also made aware over the page there was whistleblowing going on within the group. There was different agendas. Now, do you recollect this conversation with Dr. Murray?
I remember meeting Andrew, yes.
In broad terms, is he talking about the same conversation you remember happening?
I assume it will be. I have to say I only remembered the conversation when this came in.
Well, I'll ask you the question. It's suggested in this statement that Dr. Murray recollects you discussing the whistleblowing with him. Why were you discussing the whistleblowing with him?
I suspect what I was doing was describing the tensions within the team and the situation. I don't believe I'll have gone into any specific detail. I certainly, for example, don't recognise the use of the word tribal. It's not a word I would use.
I suppose the only follow-up question is, what would have been the sources of the information you were passing to him about the views in and around the whistleblowing? Where would you have got the information from? Because you weren't involved in the events as they happened. So where would you have got the information from?
So I had been at IMTs as we discussed.
So it would have been from that?
Yeah.
But you weren't at the IMTs in August 19 at the time of the removal of Dr. Inkster as lead? No. So it's perhaps an earlier IMT you're thinking of. Now you're nodding, there's a transcript.
I can't recall.
You can't recall?
Yeah.
Now, in your statement, if you go back to your statement, page 144, we asked you some questions about infection prevention control. And of course, you are not, unlike your predecessor was originally, the HI infection lead for the health board. No. But you are here. And so it may be you can help me pick up a couple of things. If you can't, let me know. You mention, however, in paragraph G on page 144, the production of a governance quality assurance framework for the Prevention Control Service, which was developed in 2019. Now, I want to check that we have the right document in mind when you see that. I wonder if I can show you what I think might be it, which is a draft from August 19, Bundle 27, Volume 8, Document 1. And just to help your memory, we'll just step forward a few pages just to see the structure of the document. Do you recognize this document?
Yes.
Right, we go back to page 9. Now, I think we've been provided with the actual first operational version only in the last day or so, because this is just a draft. Were you involved in sending us in the actual working document?
Yes, because I understand, obviously, from 2019 it was a draft, and then obviously that full disclosure, and this didn't get approved through various committees because of the escalation, and then there's subsequent versions.
So when was it actually approved? After the oversight board or before?
So it was certainly into, again, I think it was after.
Because the reason I put that way is that we had evidence earlier in the week from Miss Ward, who was the Civil Service Support Lead for the ARG committee that reviewed implementation of recommendations. You've heard of the ARG, I take it? Now, when you nod, you make life harder for the person doing the transcript. Yes. One of the matters that is mentioned in the corporate statement from the Scottish Government at paragraph 31 is a suggestion that they had some role in causing this framework, or part of what it says around hot debriefs and things in IMTs, to come into place. Could it be that the draft of this might have been started in 19, but it wasn't till 21 or later that the actual board approval was finally given for the framework?
Yes, looking at the dates.
Right, thank you. Now, if we take it off the screen, the main issue I want to ask you about IPC process related to the role of AICC and BICC. And I'll set out the sort of broad proposition, and if we need to look at something, we can.
No problem.
So there's been some criticism from some witnesses, and I have to say that I and my colleagues have observed in reading AICC minutes that to a great degree, when events are happening, possible outbreaks or, in fact, data exceedances in infection terms are happening in the Queen Elizabeth, I don't know about the other hospitals, what you see in an AICC minute is a report that is noted. You don't ever see action being decided upon in an AICC. And I wonder if you thought that was fair. Or would you phrase it in a different way?
So I think the minutes do reflect, there is a lot of detail and they are often descriptive, as you say. I think there are often a richness of discussion within a committee. Certainly when I'm chairing a committee, I like to try and bring out conversation through the committee. So I do think there are documentation of very factual evidence. They perhaps don't always pick up the richness of conversation within the committee, would probably be my reflection on committees.
Because, I mean, thinking about one of the sequence of issues that occurs almost entirely before your time as Deputy Medical Director is the sequence of decants and partial decants in the Children's Hospital. So we have the September decant, we have the transfer of patients to CDU in early 19, and then we have a closure of 6A to new admissions in the summer, August of 19. And none of those, the decision makers, to the extent there are any, appear to be senior directors and managers on advice of the IMT chair. And so how would you respond to this, that it does appear the AICC is not actually making even strategic decisions about the management of potential outbreaks or data exceedances in the acute services? It is discussing them, informing people, but in terms of management, it's not actually controlling what goes on. Would that be a fair description, or would you put it some other way?
I think I'm just trying to think my way through that, because obviously you may then go and talk to people, but within making those decisions, I think you're right, those people are not on that committee.
And I just wonder whether there was a tension between, and it may be just us as lawyers coming in and look at this from outside, that the acute services is to some extent run by three people. It is run by the general manager, the clinical lead, and the lead nurse director. But the acute services infection control committee is a greater number of people. And therefore, if a difficult decision needs to be made, it's not made by the AICC, it's made by those three people. Have I understood that correctly?
Yeah, but I think it would be with a discussion and a conversation. I don't think these groups work in isolation. It's certainly not how I would try and practice.
Are you trying to suggest there's a sort of collegiate approach to these issues?
So that's certainly the way that I always aspire to work. And I guess you're talking about AICC, and I've chaired AICC.
And so if, for example, we look at the AICC meeting of the 2nd of September 2019, that's bundle 13, document 23, page 177. We see you in the chair.
Yeah.
And if we go to the report, we think about what's happened since the previous meeting in July, there's been the closure of 6A to new admissions and the removal of the chair of the IMT. And then if we go and look at the report on page 181, which is item 11. We see quite a series of reports in here. We do see the ward is currently closed being reported, but we don't see the change to the IMT chair in here. Now, I'm not going to ask you a question yet because I want to draw a contrast with I want to look at another item on the next meeting and sort of set this up because I think there's a wider point that you may or may not accept. If we then look at the meeting of the 12th of November, so that's the same bundle. Well, it's not, it's bundle 52, volume 2, document 29. For some reason this one didn't make it to us earlier. At page 401. Again, you're in the chair. And if we go to the report on Ward 6A at page 405, we have no report of all the estate's actions that are happening at that time, because we know this is the point when the ward's about to be reopened to patients. And what I'm suggesting to you at this point is that it may be a consequence of the minuting system and not the reality. So that's what I'm trying to find out. Does an AICC attempt to capture all the major events in a major incident like this and discuss them all? In a sense, a resume of what has happened and discuss them and work out what to do? Or does it just draw out the things that are live at the time of the meeting? What's the approach to what you discuss at the AICC?
I think a lot of it is what's live at the time. I think minutes are minutes, and I don't think minutes always reflect the entire conversation. I think going forward, the benefit of having new tools such as Copilot will also help us in terms of transcribing our meetings, which we tend to do now as well. So I think there's learning.
Because the thing that occurs to me is that, and I recognize this might be an over-prescriptive question, so you should tell me if you think I'm applying too much structure to something. If it's the case that AICC is really only looking at the things that are live when it meets, then it should either meet more often or actually it's too big and it doesn't need to exist. Do you see do you think it's worth having?
Yes.
And what would you see as its value?
So I think it is the discussion, it is sharing, the hot debriefs, you get learning. We looked, for example, around, I think over time, I'm just trying to pull things, we looked at chlorhexidine dressings, for example, around cannulas. So there are things that it has achieved, and I think it's also important that we've got a record of areas as well. Is it perfect? Clearly not. But I think on balance, I've enjoyed AICC.
In a sense, the problem here being that I'm seeing the word committee and seeing some sort of executive function decision-making body. That might be my error, or its name is misunderstood.
I think potentially.
No. What I wanted to do was to look at BICC, just briefly, and sort of slightly replicate the same conversation. But I'm conscious this is a period when you weren't the chair, and I haven't got the sequences when you're the chair. So this may be it may have changed in style, so you can tell me. But if we look at the equivalent BICC minutes, so 7th of October 2019, that's bundle 13, document 59, page 433. When you are present, but you're not, of course, the chair at this point, and we go to page 435, and you see at the fifth bullet point, as we looked before, there is quite a more detailed note of what is going on. And I'll show you the next one before I ask the question. The 25th of November.
My fault, Mr. McIntosh. Which year are we?
2019, my lord. So this is 7th of October 19. So I'm trying to show Dr. Davidson two AICC and two BICs from approximately the same period in order to ask this question.
Yes.
And then 25th of November 19, bundle 42, volume 1, document 70, page 360. It also didn't get caught up in the original bundle for some reason. If you're being welcomed to this, so Dr. Armstrong is welcoming people to the meeting, and then if we go on to page 361, we see a briefing about Ward 6A, and it goes on in quite some depth. And now what I wanted just to do is to ask you, is there something there in the difference of the nature of discussion between the two committees, or are they really the same thing, just at a different level? Are they different committees or the same in terms of style?
I think they're slightly different from the minutes. I haven't attended BICC on many occasions.
Yeah. Do you attend it now?
No.
No. And that's partly because you're no longer the HIA lead?
Yes.
Right. From when you did attend BICC, did you see it as the same sort of committee as AICC, but just a higher level, or as something more executive?
No, I think it was a similar committee, just at that higher level.
Thank you. Right. What I want to do now is to ask you almost final questions around, take that off the screen, please, the reporting of HIAs by the Health Board. Now, I'm conscious that you're not the lead for this, but have you followed the various pieces of correspondence between Ms. Lamb, the Director General, the Chief Executive, and people from NSS, RHI over the past few months?
Yes.
Yes. And we ended up looking at a document that was, I think, is the current live version of the Incident Management Process Framework, which is Bundle 52, Volume 7, Document 61, page 486. Now, I understand this is the live policy at the moment, although version 4 is in creation.
Yes.
Yeah. Now, you may not be able to help us, but it would just help me a little bit. Version 2, which was in place from 23, is, I think, the version that RHI had some difficulties with. Is that your understanding as well?
I believe so.
Yes. That issue, the fact that version 3 had been produced didn't emerge until a meeting between GGC staff and NSS staff a matter of weeks ago. And yet this policy has been in place since April 25. Can you explain why GGC haven't supplied these documents to RHI once they knew there was a controversy around them? Because version 3 isn't, we have correspondence between Professor Gardner, which I'm presuming she's not writing herself entirely, and Ms. Lamb and Ms. Morgan around, is there something wrong with version 2 to some degree? And yet, version 2 had been superseded months before, and no one in GGC appears to have told RHI or the Scottish Government of version 3's existence. And it slightly mystifies me, and I wonder if you can help me about how that might have happened.
I don't know, sorry.
Okay. You were also involved in a correspondence around the production of information requested by RHI in respect of Cryptococcus infections.
Yes.
Yes. How did you become involved, since you're not the HI infection lead?
So the medical director from NSS dropped me an email to have a conversation about information release.
And is that when you first were involved?
Yes. I knew that information had gone to RHI.
Yes.
A vague, and then, as I say, Sharon got in touch with me, medical director in NSS.
Just help me, what's the surname?
Hilton Christie.
Thank you. So Dr. Hilton Christie gets in touch, and that's when we see you in the thread of events.
Yes.
Yeah. Would it be fair to say that that call might well have been to slightly break a logjam or to prompt some action?
Yes.
I suppose this is the part, you're obviously not the HI infection lead, but you are the executive medical director. And so to what extent do you think the public and equally RHI as well, but I suppose also the Scottish Government HIA unit, can have confidence that GGC is and will continue to report HIs in accordance with Chapter 3 of the National Infection Prevention Control Manual?
So certainly, I've worked with my infection control colleagues. I've met with my infection control doctor colleagues. I know that they come to work to do the absolute best that they can, and I'm assured that they report in line with Chapter 3 of the manual. And as I say, during these last meetings, I've met with colleagues. I've supported some of my colleagues over the last few years because it has been difficult. I believe they are highly qualified, very good colleagues. And I think I have confidence that they are reporting in line with the manual.
I've been asked to ask this question. What awareness do you have of the previous times that NHS GGC has not reported in accordance with the manual, including back in November 2015 when they were subject to the CNO's algorithm for that reason, and a couple of occasions since then when reports haven't gone in?
I'm not aware of non-reporting.
Okay. Now, you obviously have some knowledge about the what you didn't describe in your words as tribal, what Dr. Murray reported as tribal. The relationships amongst IPC, microbiologists and management in the hospital. And I'm not going to ask you for your understanding because it's to some degree secondary. But do you think that NHS Greater Glasgow and Clyde has done everything it can do to ensure that its culture encourages the disclosure of patient safety issues, if required, through the whistleblowing procedure?
I have no reason to believe not, and I do believe we are doing everything that we can. Yes.
Did you have some involvement in the decision by the chair and the chief executive to make a public acknowledgement and apology in responding to the HIS report into issues amongst the A&E consultants that was published earlier in the year?
Yes.
So how would you respond to the suggestion that one feature of that response is a public acknowledgement that those consultants should not have had to whistleblow in order for their issues to be addressed? Would that be something you'd accept that as part of that response?
Yes.
Do you feel such a response is required by the Health Board in respect of these whistleblowers?
So I think we're sitting in a public inquiry. I think even on a personal note, I feel an acknowledgement is an apology for every patient, family member, staff, both internal and external, that requires to be acknowledged, and we need to learn from the inquiry, and we need to move on and ensure that we have that culture and environment going forward.
Yes, ma'am. Dr. Davidson, my lord, I think that's all the questions I have, but of course we need to see if any questions in the room arise. I wonder if we might take an early coffee break, because that would enable us to both have questions ready for Dr. Davidson, but also I'm not expecting Professor Gardner in the building till 11:30, though she may of course come early, so I need to find out whether she's here.
I think she may have come early.
But if we take the coffee break now, I can sort of do both things.
Right. Do you want to take a slightly longer coffee break or?
Yes, maybe till 25. Well, we need to ask the questions of, if there are any, of course. Maybe until 25 past, that might help.
Right. Doctor, as Ms. McIntosh has explained, he's asked you the questions he wishes to ask you, but he wants to check with colleagues whether there are other questions out there. So what we'll do is we'll take 25 minutes, which is longer than he requires for that. But during that period of time, I hope you're at least offered a cup of coffee. But can I invite you to return to the witness room?
Thank you.
Right, we'll sit again at 25 past. Mr. McIntosh?
Well, I have three questions.
Perhaps three questions, Dr. Davidson. No, Mr. McIntosh.
My Lord, three questions. The first question is, I was reminded that we've had quite a lot of evidence about cystic fibrosis patients, various IMTs that took place in the events we're interested in around infections in that cohort. And I wondered if you knew whether there'd been a risk assessment of the ventilation system in the cystic fibrosis ward, given that it does operate at less than half the levels air change rates set out in the Scottish Health Technical Memorandum.
I'm not aware of a formal risk assessment.
Do you think one would be a good idea, given the vulnerability of cystic fibrosis patients?
I can't see any reason why not.
What's the disadvantages of not doing a risk assessment?
I don't think there are any.
So there's no particular reason to do one then? If there's no disadvantages of not doing it, then there's no reason to do it, isn't it?
Sorry, I'm just picking up two negatives.
Sorry, that's my fault.
I think I was confused by the number of...
Is there any disadvantage that flows from not doing a risk assessment?
Any disadvantage from not doing one? Sorry. Sorry, I'm just trying to get my head right.
If one hasn't been done,
Yep.
does the fact that one hasn't been done cause a disadvantage? Cause any harm or risk or question of safety or anything like that?
I'm not aware of any significant issues, so I don't think so.
I asked you a question about HAI reporting in compliance with the manual, and you expressed confidence in the work of your colleagues in IPC to report.
Yes.
And I'm asked, what have you done to check that they are actually reporting in compliance with the manual?
So what I've done to check is simply to talk to my colleagues, work with my colleagues, and have confidence in my colleagues.
Now, in the last question before the coffee break, I asked you, and I have a note here, do you feel, and this is in the context of acknowledgement of whistleblowers, do you feel such an acknowledgement is required by the health board in respect to these whistleblowers? And what I have noted, or my learned junior has noted, is you said something like this. So I think we're sitting in a public inquiry. I think even on a personal note, I feel an acknowledgement is an apology for every patient, family member, staff, both internal and external, that required to be acknowledged. And we need to learn from the inquiry, and we need to move on and ensure that we have that culture and environment going forward. Now, what does that mean? Because what you said was, after mentioning that we're a public inquiry and making the remark a personal note, you then said, I feel an acknowledgement is an apology for a list of people that required to be acknowledged. And I wonder what that means.
So I think, try and put it another way, I think so as a clinician who's worked in the Queen Elizabeth since it's opened, I think it's been a complex hospital to work in. The media around it, in terms of lots of issues, has been challenging. The issues that we've seen, we've talked about the relationships that we've talked about, and I think moving forward, I would like to see the public inquiry, if you like, as a process that will come up with recommendations and findings that allows us all, I think, to get into a place where we can start to talk about the huge amount of good that is done. As someone who's practicing there 10 years and in my role, the good things that I see being done across Greater Glasgow and Clyde are immense. Some of that, and a lot of that, come from the Queen Elizabeth University Hospital and the Royal Hospital for Children. And I think I would like us to be in a position where we can celebrate that so much more than we can at the moment. And I think the public inquiry is an important step in that.
The question I asked you originally was, given that you've been involved to some degree in the decision of the chair and the chief executive to make a public acknowledgement and apology in response to the HIS report,
Yes.
amongst the A&E consultants that was published earlier in the year, how do you respond to the suggestion that one feature of that response is a public acknowledgement? Those consultants should not have had to whistleblow, and you accepted that was part of the response. And I ask you, do you feel that such an acknowledgement is required by the health board in respect to these whistleblowers? And I'm not sure you've actually answered that question. So what is it?
Sorry, I thought I had.
So what do you feel that such an acknowledgement, equivalent to the HIS one, is required by the health board in respect to the whistleblowers that this inquiry has heard from?
So I think in terms of, again, I think it's important to acknowledge everyone involved and affected. That includes whistleblowers, it includes colleagues, it includes patients, it includes families.
Now, we can read the words of the chief executive and the chair at the board meeting earlier this year. Are you suggesting that a broad acknowledgement of everybody and everyone's role is what they said about the HIS case? Because are you describing the same thing or something different?
I haven't got that in front of me. I think I'm expressing my thoughts.
Okay. So I'll make the question more precise then, because maybe I didn't make it precise enough. Do you feel that the health board requires to make an acknowledgement to these whistleblowers that they should not have had to whistleblow in order for the issues they raised to be raised?
So I would like to be in an environment where whistleblowing is really important, that it's there so that people have that. But I would like to be in a situation where whistleblowing is almost a never event. So yes.
So there should be an acknowledgement.
So I think there's an acknowledgement to colleagues, yes.
No, I'm sorry to do this, but
Okay,
I'm going to have to press you. You've acknowledged that there was some form of acknowledgement to the A&E consultants in the board's response to the HS report. And I'm asking you whether the board needs to make an equivalent acknowledgement to these whistleblowers. And whilst I may have misunderstood your answer, I'll have to read the transcript with care when it's being produced. I'm not getting a definitive yes or no from you. I'm getting a discussion of the need to move on, to learn to have an environment that is positive for whistleblowers. And those things may all well be true, but they're not actually an answer to the question I asked you, which is, do you think the board needs to make a specific acknowledgement to these whistleblowers as it did to the A&E ones? And it might well just be a yes or no answer. I can ask you for your reasons once you've given it.
So I'm obviously one member of the board, and I feel that yes, there should be an acknowledgement to those colleagues, whistleblowers.
Mm-hmm.
Yes.
Thank you. My Lord, I have no more questions for Dr. Davidson.
You don't want to say anything
No, I was just breathing, Lord.
Dr. Davidson, that means you, that's an end to your evidence, and you're free to go. But before you do that, can I thank you for your attendance here this morning, but also the preparation of your written statement and the background work that will inevitably have been involved in that in the context of your many other duties. So You're free to go, but with my thanks.
Thank you. Thank you.
My Lord, I'm pleased to report that Professor Gardner has, at our request, arrived early, and she's now available to start her evidence now, my Lord.
Perhaps just 2 minutes.
I'm happy to wait.
Please sit down, Professor Gardner.
Thank you. Good morning.
Good morning.
Good morning.
Now, as you appreciate, you're about to be asked questions by Mr. McIntosh, who's sitting opposite. But before you do that, I understand you're prepared to take the oath.
Yes, thank you.
Sitting where you are, can I ask you to raise your right hand and repeat these words after me? I swear by Almighty God
I swear by Almighty God
that I will tell the truth,
that I will tell the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you very much, Professor.
Thank you.
Now, we will sit until 1 o'clock and take a lunch break of about an hour and resume in the afternoon. If, on the other hand, you wish to take a break at any stage, just give me an indication and we can take a break.
Thank you very much.
Now, Mr. McIntosh.
Thank you, Lord. Professor, firstly, thank you for agreeing to come early to accommodate what I anticipated to be a shorter piece of evidence from Dr. Davidson. Can I take your full name?
Jann Catherine Susan Gardner.
Thank you. And did you produce a statement for the inquiry?
I did, yes.
Are you willing to adopt that as part of your evidence?
I am, yes.
Thank you.
Thank you.
Did you also, did the Health Board also produce a paper setting out the board's approach to governance, which is been attached to bundle 50? It is the last document in that bundle at page 73, which I think was produced as part of a response to one of our position papers on governance.
Yes, I did.
Yes. Now, what I asked to be done is to see if you would adopt this as part of your statement,
Yes, happy to do
because
so.
it simply came in a bit late for the process, and therefore I didn't want to be in a position where we couldn't think about it. So thank you for that. We'll come back to that. In your statement, paragraph 1, you explained that you were appointed as Chief Executive of NHS Greater Glasgow and Clyde on the 1st of February 2025. When did you learn that you were going to be the new Chief Executive?
The process took place through September, and that was confirmed by the end of September, and I then came into post, as you've said, on the 1st of February 2025.
Might there have been a public announcement on the last day of October?
Yes, indeed.
Now, we've heard from Professor Brown, who was the previous chair, that before Ms. Grant was appointed, he had a discussion with her about the issues facing the board. I didn't ask Ms. Grant that question. It didn't occur to me, but that's what he explained. I wondered if you'd had a similar conversation with the current chair before you accepted the appointment.
Yes, I was aware of the issues in Glasgow. Those were raised to me by the current chair, and I also had brief discussions with the outgoing Chief Executive prior to taking up post.
So if we, as it were, place you back at around about that time, what did you consider to be the principal challenges that you would need to address or face as the new Chief Executive of NHS Greater Glasgow and Clyde?
So coming into the role in relation to the issues of the Scottish Hospital inquiry?
No, just in general, because we're very conscious that when we were talking about the procurement of the hospital, we're interested in the ventilation system, and there were lots of other issues. So it's always useful, I think, to check context. So in terms of what was on your to-do list, and if it's not the reference to the inquiry, you don't have to mention confidential matters, but did you have a list of things that were on your to-do list for your start?
Yes, so obviously NHS Greater Glasgow and Clyde is the largest NHS organisation in Scotland, serving over 1.5 million people. It also provides regional and national services, the national obviously to people across Scotland. So I was very thoughtful coming in. I was conscious of the issues within the Scottish Hospitals inquiry and the journey from the build of the Queen Elizabeth. I was also very thoughtful about the need for the organisation at a time and place to be able to transform in a way that would allow us to go forward into the future in a more resilient manner. Demand and population demographics are changing, and that means that healthcare cannot stand still. Financial challenges, etc., in the landscape mean that we need to do things differently. So as I was coming in, my priority was first of all to really assess the organisation I was coming into. I was looking across the 4 quadrants of good governance, which would be workforce, finance, performance and clinical safety. And my assessment really is built around those elements coming in to understand better the organisation and to take my time to understand what was needed. In high terms, in high
Before
levels...
you go on, whilst we have a highly efficient transcriber working behind the scenes, his lordship is about to tell you that he's trying to take an approximate note, as is my learned junior, Mr. McKeever.
Yes, I mean,
Apologies.
Professor, I mean, there's a question of pace. There's maybe a question of purpose of what you're saying. You might bear these things in mind. I mean, I came to the conclusion that this was not part of your evidence, that I was going to be able to note, and perhaps it wasn't intended to be noted, but yeah, bear in mind that I can only write so fast.
Would it be fair to say that the issues around the Queen Elizabeth were just one of the issues?
Yes, if I may reframe that piece then. So strategically, I was looking to understand the issues in the organisation and to set a new direction harnessed with technology and modernised healthcare system. But I was also looking specifically at the areas that I thought were of concern within the organisation. I needed to develop a better understanding, and to do that I was looking at data. I was getting out and about to understand from people directly what was happening. And then quickly into my tenure, although that is moving on, we had the issue with Health Improvement Scotland, which is referenced later on. But as I came in, strategically setting the direction, understanding better the issues from my own perspective.
So in a sense, you're saying that you have a series of aspirations around developing the service in the financial demographic environment that you're in.
Indeed.
But you also need to look back at a certain number of issues, of which this topic of this inquiry is one. I mean, there may be others.
Yes, and I think primarily my role is to be able to give public confidence, to provide a service to the people that we are here to serve, where they can come to receive that care safely, and that they can be confident in doing so, and they can do so with their families without anxiety. The second part linked to that that's really important is that our staff can come to work. People come to work in healthcare because they want to make a difference, and that they can come to work knowing that the landscape has created the right conditions for their success clinically, and also where they will feel valued and empowered. So those are the critical elements.
Thinking about the issues around this that we're interested in this inquiry. So that's the procurement of the hospital, the management of issues as they arose, the question of whether GGC encourages the raising of patient safety issues through the whistleblowing process, the question of whether GGC has learnt from any issues around HR reporting. When you were about to take the job, how much understanding did you have of the scale of these issues?
I had some understanding. I had done work prior to coming in to try to understand better, but it would absolutely be fair to say that now 8 months into the role, I have a much greater understanding of those issues, and actually much more of the landscape and the challenges during that journey. Clearly in 2025, we're a very different organisation from 2015, and that has been a significant journey. It's not a moment in time here and there. So I have learned.
And just thinking about your career before you arrived, and so have you previously had experience of dealing with organisations that to some degree have had issues of controversy, public note, problems? I mean, there's all euphemisms, I realise, in their past that have required to some degree to be learnt from or moved on. Is that something you've come across before in your previous career?
I've had a significant career. I began as a clinician, and I've moved through increasingly more senior management roles. At a senior level, I've been Deputy Chief Executive of NHS Fife, Chief Executive at NHS Golden Jubilee, Chief Executive of NHS Lanarkshire, and then coming to NHS Greater Glasgow and Clyde. So it would be fair to say that during that journey you will meet challenges in a complex healthcare system. I have been involved whilst I was in Forth Valley with the capital build of Forth Valley Royal Infirmary.
So that's the new hospital at Larbert?
Indeed. And I was part of the team that developed the journey towards going into that hospital. At NHS Golden Jubilee, I was involved again with the development of phase 1 and phase 2 of that capital build. I'm speaking specifically about building matters here.
Yes, of course.
But of course, on a day-to-day basis, on a week-to-week basis, when you work in an area where you are giving public assurance, you will be tested both politically and indeed by the public directly. So there are very often matters of issue being raised. They may be with staff, they may be in HR processes, they may be issues of incidents that families are querying. So many, many issues across that level of experience of role.
Thank you. Now, what I want to do is just pick up an issue I've been asked to raise with you, which is whether there is a body within the board now created called the Rectification Board, which it's been suggested to me, might report to capital planning, be chaired by Ms McIntyre, and be in charge of fixing the defects that are the subject of the legal action against Multiplex and others. Is that something that exists?
So in terms of the delegation, of course, the inquiry has heard before that I delegate the responsibility to my Director of Estates and Facilities, who gives me assurance. He in turn will deputise to different elements within his team, and there are also authorised individuals and authorised engineers reporting, etc. There is an entire structure that's set out within the governance paper that describes the different elements of flow up and through into our committee structure. I wouldn't attend those meetings.
But
should
does
any
such a
issue-
thing exist, is the question.
I don't think we have an answer to the question.
Yeah, the question is-
I think was, does such a body exist?
Yes.
I don't know.
Right.
Right.
Now, this is a good question to raise another issue that has been raised quite a lot in evidence. We've had a lot of evidence about the management structure of the health board, which doesn't seem unusual for Scotland, in that you have in sectors or parts of service, you'll have a general manager, you'll have a clinical director, and you'll have a lead lead nurse director, and that will operate in a number of different layers within the organisation, up to and ultimately the chief executive level, because there'll be the medical director and there'll be the nursing director, amongst others at top level. Now, we've also had a lot of evidence about assurance, and you just said that your Director of Estates will give you assurance. Now, one of the features that seems to have come out in evidence is there seems to have been a system where a general manager at any of these levels would work on the basis that if matters weren't reported to them by their reporting lines, then nothing was wrong. And it's only by exception reporting that you would learn there was a problem.
No, so assurance works in two different approaches. One is proactive and one is reactive. In a proactive basis flowing up to the board level, there will be reports as set out in a paper earlier this year to the board in terms of coming in as a new accountable officer, the different elements of being assured that planned maintenance was being undertaken. So there are schedules of planned maintenance, and there are reports to note on a monthly basis that planned maintenance is taking place proactively. At times in a healthcare setting, something may need to be rearranged, but it's only escalated if they cannot be rearranged, for example.
So your understanding of receiving assurance is a regular cycle of reports that should effectively, if everything is going well, saying, we've done it, we're up to speed, and here's some evidence.
Proactive, reactive. So level one is proactive. The reports are coming from from estates and facilities, from the monitoring. So I know that things are being effectively monitored. Then I know that the data is being assessed, and then I know the assessment of that data, and that comes up through flow. And the second point, if I may, is that there is reactive. So if at any point there are points of concerns, those would be raised if they couldn't be rectified.
So I understand the split. I just want to translate this into something that I've been thinking about. So I may not use the terms you use. So is it your position that now, whatever happened in the past, but now, those reporting to you are required to report proactively that they are meeting whatever standard is set for their service, but also to report when those standards can't be met, whenever that happens?
They can't be met and they can't be resolved. Yeah. So in the first instance, it would be their responsibility to resolve that matter and bring it to the fore. Either if it was a complex resolution that required the executive and indeed potentially the board to be aware of it, if it was required.
But if the news is we have continued to meet the standard that is set for us, you would receive a report effectively saying that on a monthly basis.
I would know that the proactive work was happening, and then the reactive work would be the reactive element, yes.
How would you know? Would you be told, or would you presume?
In the proactive or the reactive, sorry.
The one that happens regular. So I don't
regular-
understand the proactive reactive difference. Let me explore it with you.
So-
As I'm understanding it at the moment, you're distinguishing, and you give the example of plant maintenance, a proactive approach, which is to ensure that there is no difficulty or failure of delivery of service. And in the course of that proactive, a really discharge of the obligation
Yes.
of the responsible manager, if he or she detects something which he or she can't resolve,
Yes,
there would then be reactive reporting.
yes.
I think what Council is exploring with you at this particular moment is that, accepting your terminology, how do you get routine assurance that the proactive discharge of responsibility is actually happening?
Yes. So it's if we take estates as an example, and let's use an example that a particular piece of equipment of significant importance to the board is being successfully maintained and validated whenever it has to be done. Presumably there's somewhere down the organisation a person whose job that is. The fact that they have done it successfully and all is well, is that reported by them as a matter of routine to the layer above? Even if the
Yes.
layer above doesn't notice, they still get told it.
Yes, and so that is through those individuals, and so there's formal elements.
So you looking at the document that I've asked you to adopt as part of your statement?
Yes,
Brilliant.
yes, in terms
So
of,
if we it starts on page 73. Let's look on the screen because we can actually, because the version that we have is incorporated into a bundle.
Yeah.
So if you look on the screen, tell me what number you're looking at, paragraph number.
it says page 73, and I'm just looking at the general, the hierarchical.
Yeah.
So if we can move forward.
To page
I'll
74.
I'll bring up it, so if you just.
If you tell me the paragraph number, then we can jump straight to it, you see.
So in terms of if we go to page 7 in that document.
That will be 78, I think.
So that's describing at a very high level.
So which section is this?
Apologies, page 7, which
Yes,
is one.
maybe,
Yes, this one.
Page 79, right.
Yes. So if we look to the flow up into our corporate management team, so in terms of what happens on a regular basis, to give you that sense, on a weekly basis, the directors will meet each week. If there is an informal issue, a director may raise it for discussion with the directors, the executive directors. They'll either raise it informally or formally in that space. If it's to be raised for either an assurance point or if it's raised for decision, it goes up to the corporate management team where decisions are made, and then you can see onward the flow into the board.
So let's continue to use a vital piece of equipment as an example.
Yes.
So let us place that vital piece of equipment in a particular, in figure 2.
Yeah.
We would place it in and zoom in to make that chart bigger. I imagine it would sit.
So it depends. So it will come up potentially through capital planning. It may come up through health and safety forum. If it was, for example, a ligature issue, it may come up through the board clinical governance committee.
Let's imagine it's the board computer system. So it will appear in digital healthcare and strategy board.
Indeed.
Right. So
but the ramifications of it, if, for example, and that's
where...
Yeah,
but I just want to focus, very tight question, just check I've understood correctly. So let's imagine big computer system the board owns. Every year, it needs to go through a process where someone externally comes in and checks it's working.
Yes.
And every year that happens because people do their job.
Yes.
Does the fact that it has happened and there's nothing untoward get actively reported to the layer above the person who does the actual work?
Yes, it does. And in relation to the estates and facilities, there are accredited competent authorised persons, and then there is an authorised engineer who will put in an annual report. But these elements, the authorised person, on a daily basis, weekly basis, they are giving reports up to the layer above, and they have a series of checks and balances of what should be done. If they're being done, that's accepted. If it's not being done, it's escalated, and so on. If it can't be resolved, it would continue in its escalation.
And if it's
path.
important in terms of risk to the board, it goes higher up the structure.
Yes, and for example, if there was then a need for capital to be assigned to that because there is a rectification required, it would come up through potentially one of these groups, depending on what the issue were.
So let's pick an issue from the past. The non-escalation of the 2015 DMA Canyon L8 risk assessment. So are you familiar with the Mr. Leaper's investigation?
I am, but I think to comment on the structure that was in place at that time.
I'm not going to ask you to comment on the structure.
Thank you.
I'm going to ask you to comment on what happens now. And of course, there's not a new hospital being built now. But just for the sake of humouring me, imagine a new hospital is being built now. And we know that one of the things that has to happen is a assessment being done before occupation. If it's done, would it be reported as part of the management rules for that service up in the structure? And if it's not done, how can we be sure that the people higher up the organisation know to look for it to be done?
So I think there's 2 points I think we need to differentiate from here. One is this a new capital plan?
Yeah.
So if this is a new build, you would have a new infrastructure. The way that we build today is very different from 2015 because of NHS Assure being in place. And I've had that proactive experience of having been part of Forth Valley Royal and then being part of NHS Golden Jubilee. As Golden Jubilee moved to phase 2, NHS Assure came into being. So it's a very different structure. So the structure's in place.
Can I?
Sorry.
I apologise for interruption.
No.
The example we're looking at, just as to explore this point, is the pre-occupation risk assessment, which is a requirement of,
Yes.
as you have already demonstrated, you're aware of L8 taken with SHTM 0401. Now, that requirement is still current, and it's at the point of when the hospital is about to be occupied.
Yes.
Now, as I understand the KSAR process, that will all have been in the past. So taking this example, allowing for the fact that things have changed, have things changed in relation to this? In other words, it's still a requirement, and it's a requirement which may have to be discharged at a stage after NHS Assure has completed the KSAR
So the question I'm asking is, one of the concerns that has emerged around the L8 risk assessment in 2015 was that it was not escalated to the next layer up in the structure, and ultimately appears not to have reached the knowledge of the board water safety group, the two chairs of that, and so on up the structure towards the duty holder, the chief executive. And there are a number of reasons that have emerged in evidence around that, to do with resource levels, possibly to do with knowledge of technical issues, to do with whether people have been appointed to various jobs, and to do with the state of knowledge of the chief executive of their duties. But what I'm trying to get, and I appreciate that this system is a modern system, developed now, not 10 years ago, is how can you be sure that the events that arise out of the maintenance and operation of buildings that have the potential to have significant risks to the whole board's services will always be reported up to through the structure if they're not actually going to plan? How can you be sure of that?
So in terms of the structures that we have now and the learning of the last 10 years, it's really significant. we're describing almost a fictitious structure right now, but if we assume that structure, I would absolutely expect, given the way that buildings are built now, that the programme team would escalate that. And the reason that I'm confident of that is how you commission the report to be done in the first place. So the person who committed to commission that DMA Canyon water report, they should have, there should have been knowledge at a senior enough level of the commission of that. So today, if something of that ilk was being commissioned, I would know about it, or one of my executives would know there is a commission in place. Therefore, there is a requirement.
So that's a sort of financial check, independent
it's
of
a
the
check and balance, really, that one, it should come back up, but you have to have the safety element of you will check to close that loop.
So does this amount to this, that when something needs to be done that involves commissioning an external service, not only should you know about it through the normal structure, but the very fact that you've commissioned an external service will also result in the system knowing about it.
Indeed.
That's really helpful.
Indeed.
Thank you. What I want to do now is think about the question of reporting of healthcare acquired infections to RHI.
Yes.
And now, I do appreciate that you're not an expert in infection prevention and control. And I think you mentioned that in your statement on page 57, when we asked you some preliminary questions about this in question 3. And of course, since you wrote this statement, lots of things have happened. So what I want to do is to slightly laboriously, because it's just easier for our understanding, walk you through the process. Along the way, there are questions, and indeed you may have things you wish to say. But the reason I'm going to do it slowly is it certainly helps me understand. So let's ground ourselves to this questionnaire. So the incident management process framework that's referred to here is 27, volume 17, document 28, page 315. And this is the version 2 from December 23 with a review date of December 25. And if we go to page 317, we find the bit that, if I understand correctly, RHI doesn't like, which is at 2.1.
Indeed.
Now, I'm not going to ask you to explain why they don't like it, because you're not an IPC expert. What I want to just understand is, when do you first become aware that there is a challenge from RHI to this version 2 of the framework?
So it takes time to understand that it is a direct challenge from RHI.
I understand that.
What I first became aware of was that we had, we believed, it was being raised with me that we believed that we should improve our procedure. And in April 2025
So this year.
of this year, so I had been in post for a couple of months by that point, it was raised with me that we were reviewing the procedure to improve its alignment with the national standards. And I didn't, at that point in time, dig any further into why and who and how. And that's a learning journey in this piece. But at that point, it was being raised with me that we intended to improve our procedure to give greater alignment to NIPC.
Just to clarify this, if we look at, so I wasn't intending to show you this version of it, but since we've got here, we might do that. Now, I'm going to come back to that because I think it probably should be, but there is a version 3.
Version 3.
Yeah.
So what was in existence was version 2, and that makes reference, as you've said here, in terms of the 2 elements of how we're approaching our management.
So at that point, and of course you've only been in post 2 and a bit months at this point, someone comes to you and says, we need to improve our alignment with our processes with the manual.
Yes,
And here's a new version 3. Let's put it through the governance structures.
yes,
And that's done.
and that's done.
And it goes on the website.
Yes.
Who comes to you?
Director of Nursing, Executive Director of Nursing.
And that is?
Angela Wallace.
Right. And no one mentions to you at the time, and it may be just that you're new in the job and there's lots going on, but no one actually mentions to you that RHI have challenged version 2.
So I'm aware in the background through the coming into post that there has been concerns around Glasgow's management, but it's not specific into this is being done in response. We don't really have that protracted discussion around that at that time,
Right.
not to my recollection.
Okay. But,
And something may have been said, and I haven't placed it
No, I understand that.
with the level of importance at that time.
however, in August,
Yes.
20th of August, you get a letter
Yes.
from Caroline Lamb. Now, before we, Director General of Health and Social Care, before we go and look at the letter, between April and that process that approved version 3
Yes.
and 20th of August, has the question of IPC and HIA reporting crossed your radar at all in that intervening 4 months?
Yes, so there have been discussions around the fact there is a request for information. I remember.
This is about Cryptococcus case.
This about Cryptococcus, yes. And that has been raised by both Angela Wallace, Executive Director of Nursing, and Scott Davidson, our Medical Director, in terms of aiming to resolve and get the information back.
Because Dr. Davidson's just given evidence that he was contacted by the clinical lead, medical director, for
Yes.
RHI, whose name now temporarily escapes me, in order to some extent, prompt action.
Expedite, yes.
Expedite, that's the word he
Yes.
used. So,
And I'm made aware of that.
right.
I'm made aware of that in July. And I then query why it has taken so long. It's taken far too long for us to respond. And so I therefore am asking to expedite. Can we please ensure that this information is returned?
Thank you. Well, we're going to go to the document. I couldn't remember the reference. So version 3, it's bundle 52, volume 7, document 61, page 486.
And actually, as you're bringing this up, if I may, I'm asking, does this comply in the way?
You're asking, does this comply?
Does this comply? And I'm being assured that it does, version 3.
Right. And if we go on to page 489, yes, we have a new version of paragraph 2.1.
Yes.
And we're actually told by RHI that this paragraph does comply.
Yes.
We just heard that a week and a half ago. Take it off the screen. Let's go back. So back to July, you're asking questions around this Cryptococcus data set. And indeed, it is then supplied to RHI. I get the impression relatively quickly after your intervention.
Yes.
Can you help us about why it took an intervention from both the Executive Medical Director and you to produce material for RHI that some of which have been requested some months before?
Yes. I don't think there is a clear, good explanation for why it did. There was concerns being raised within the team. I do not think that they are reasonable concerns, and I think going forward, I am confident going forward, we will not be in that position again, and been very clear that when we are asked to provide information, and of course that begins to unpack in what we will presumably move into in August and September, that we respond in a very timely manner. The issues that were being raised, I don't think are unreasonable, that people should have some concerns. They're asking about patient information governance and what we should.
So they in this context is RHI?
I beg your pardon?
They in this context is RHI?
Apologies. They are the infection control team in NHS
right, they are.
Greater
Sorry,
Glasgow
right, yes,
and Clyde.
yes.
I'm saying, why have we not provided this information? Why are we not? And I'm given a series of explanations, which, whilst not in themselves are unreasonable, they are points that should have been resolved in a timely way. So I don't think we responded in a timely manner.
I understand.
And I've been clear with my colleagues and onward that we need to respond in any future request in a timely manner and raise points and resolve points in a timely manner.
However,
It's probably sufficient that I have your view that the explanations coming from the infection prevention and control team were in in your view, not reasonable. Did they include reference to patient confidentiality?
They did, yes, in terms of information governance, and Dr Davidson explores that and speaks to colleagues to reassure them and ensures the Caldecott Guardian has been involved in that discussion to resolve that matter.
This is in the context of routine reporting from a health board to RHI.
Indeed, but I don't think we should be concerned about these matters. There is a methodology that we can use to assure ourselves in terms of the process. So I understand why people were saying they were concerned. I don't think it should have caused the delay that it did.
Thank you.
Let's look at the letter and move the story forward. So this is in the letter from 20th August. It's bundle 52, volume 5, document 31, page 144. Now, what we might just do is just check we've got the whole letter. So this is the first page on 144, and 145 is the second page, and it's been copied to the interim chief nursing officer, Ms. Critchley, NSS, and your Professor Wallace. Now, if we go back to the front of the letter. So firstly, we've all read this, but just from your point of view, what did you take from this letter?
So what the net message from this was we had provided information, but it still had not satisfied RHI in terms of we had not provided the information that they were requiring in order to be assured, and that we needed to progress forward.
Is there anything that we should draw as significant or relevant by the fact that the author of this letter is not Ms. Morgan at RHI, but the Director General herself?
I think that's of concern. I also think it's of concern that from July, no one had come back to say we would, to my knowledge, to say we need further information. But I think what we can see throughout this, and we'll continue to come back to that, is there is clearly a tension in the relationship between the NHS GGC infection control team and RHI. And we go on to explore that further in, presumably in the letters that will come.
Well, I'm sure we will, and we probably better do it then.
Yes.
What did you do when you received this letter?
I am concerned because it raises to me that there is something wrong in this flow of information, and that somehow Scottish Government are now not content that the information flowing back and forward between NHS Greater Glasgow and Clyde and RHI is right, and that they feel they need to intervene. I think what's clear is I had thought that in the 20th of July, when the response had been given, it was responding to the questions in the way that was required. This says to me that there is concern that that is not the case, and of course that goes on to become the case and becomes clearer. And in totality, again, it raises with me the work that is needing to be done in this space, and again we'll begin to unpack
because
that.
One of the things that occurs to me is that the request was for sufficient information for RHI to carry out its own assessment of
Yes.
whether there was an issue here.
Yes.
And this letter explains at the end of the third substantive paragraph, just the 4 lines at the bottom of the page, the information received on
Yes.
20th of July. So that's exactly a month before. And then there is a
Yes.
statement of what the assessment is. Now, we have evidence from Miss Imrie there might be a small error here, that actually the letter should have said that the assessment identified an area in the new hospital and the retained estate. But the point is, an assessment is set out there anyway.
Indeed. Yes.
And then over the page, they say at the bottom of it, RHI observed it would be prudent for GGC to undertake further investigation into these cases in order over the page to determine whether they should be defined and reported nationally as a cluster. And then, of course, a further root cause analysis should be undertaken to explore the possibility. Yes. Now, who did you anticipate from this sentence is it being proposed to carry out the root cause analysis?
I think what this letter intends is that that Glasgow should have considered itself, but also it should have had discussion with RHI, and RHI should have been involved in discussing and considering the criteria by which Glasgow was making its decision for onward reporting, given the set of circumstances.
Now, can I just take a moment to step out and just, as it were, at the risk of being told, of course, can I check your level of comfort at this point with the
Yeah.
general topic of how one manages infection prevention control? Have you come across the concept of a root cause analysis at this point before?
Yes, I have.
Right.
Yes.
And are you familiar with IMTs and PAGs?
Yes, I am.
From a managerial
From a
perspective?
managerial position, yes,
Right.
I am.
So, are you aware that following the oversight board, there would have been a recommendation that root cause analysis should have been normally used in IMT processes?
Yes, I am, and I am asking now more questions of my colleagues to understand better the circumstances and be briefed on what has taken place in order to assure ourselves that that the root cause has been considered and the process that we have gone through.
And then you've got 3 requests that Ms. Lamb makes.
Yes.
She wants immediate confirmation they've been escalated through the appropriate channels.
Yes.
That the board, and when you mean the board, do you think she means the board as in the people who are on the board, or the board corporately in a more diffuse sense?
So in this regard, I've taken it that the executive are aware of this and are looking at this with the potential that we need to then onward escalate this to clinical governance and note clinical governance as a committee of the board that there are concerns.
So this is you're reading this as a check that clinical governments are fully aware.
Yes.
Right. And then some confirmation that reporting is handled as required in
That we're
the
compliant.
manual, because DL 2024-24 makes reference to the manual.
To the manual.
Right. And she gives you a rather tight deadline.
She does.
And then will request further information around these cases.
And she's requesting further information, which I'm reading to be then a breakdown case by case, which has to be returned to RHI no later than the 8th of September.
Yes. Now, you send a holding reply, which I won't put on the screen, but you do have a send your letter on the 26th of August, I think, with everyone's consent.
Yes.
Bundle 52, Volume 5, Document 32, page 146. Now, I've got a lot of questions about this letter.
Yes.
Before I ask you them, it might be worth just exploring with you what you thought your objective was, what you were trying to achieve by sending this letter.
I was trying to give, first of all, setting a context of how we had approached looking at the information. I was trying to give an assurance that we wanted to make sure clinicians were involved in decisions around it. So when there is an issue, I was trying to make a point in paragraph 4 around the fact that you would want your microbiology, your infection control, and those people involved in looking after patients involved.
Can I just explore that with you, because it's quite interesting in the context. So we're keen to ensure, you say in the 4th paragraph, that the patient's clinical teams, and by that I assume you mean the clinicians responsible for treating that patient.
Yes.
Yes. Have the opportunity to contribute to the collection of this information. Now that means the information that's being requested for RHI.
Yes.
Right. And then you wouldn't apologise for the delay, but you explain your reason. Now, normally when a report is being made to RHI through the online reporting tool, clinicians wouldn't be involved in collecting together information at normal level, would they?
No, but they would be involved, as I understand it, in that initial assessment of whether a case should be escalated. What you're looking at the full circumstances. So, for example, what has been the reporting from a microbiology perspective? What are infection control team looking at, and what is happening in the patient's clinical condition? So, what's happening in their blood results? What they're seeing in that patient? Are they becoming more unwell, less unwell? What have they seen in that patient population or subpopulation that they're looking at? That's what I mean by that.
Piece of evidence, which if I've understood it correctly from Miss Imrie, is that initial assessment of whether the various categories of outbreaks, data exceedance, etc., in Chapter 3 of the manual can be done by a single IPC clinician. It doesn't require a PAG.
It does not.
No. So
it does not. However, it does help build up a clearer picture.
So you're doing this in order to build collegiate
It's
effect.
more to, it's collegiate, but it also does help understanding, particularly when it's often within a subpopulation of the patient cohort who will have specific issues. So, for example, in renal patients, for example, in bone marrow transplant, etc. So that's often why it can aid the discussion.
Now, if we go to the previous few paragraphs, there's some sentences I want to explore with you. So it's the second paragraph. It is recognised that the Queen Elizabeth, Scotland's largest hospital, hosts some highly specialised units, including renal inpatient transplant units, adults and paediatric bone marrow transplant, haematology, oncology, infectious diseases, which includes patients with HIV. The occurrence of sporadic Cryptococcus SP cases within the specific patient cohorts on this campus are expected, although occur infrequently. Now, what I'm putting to you is that occurrence of cases might be higher in some of those groups that you've listed than others.
Indeed, and also the different types of Cryptococcus,
Indeed.
as I understand, again, and I'm not going into that expert opinion in this space, but of course there are the different types, and I don't seek to unpack that then.
So one of the documents that we have, and I don't know whether you saw it before you saw it on the document list, was a report prepared in early 2019 by Dr. Kennedy, who I think is still working for the board. Have you come across him?
Nope.
No. But Dr. Kennedy was asked by Dr. Armstrong in 2018 to assist the IMT, and he attended most of the IMTs from almost the start of the water incident. And he provided a number of reports. This one is Bundle 24, Volume 3, Document 3, page 19. Now, if we go back one page, it's a short document. It's reviewing the Cryptococcus species in GGC. So it's the whole GGC, not just the Queen Elizabeth.
Yes.
And then there are 19 cases. You can see it says summary number 19. And then over the page, we have a very bright, colourful chart, which reports no cases of Cryptococcus in the renal population of GGC over a 9-year period.
Reported.
Yes, I appreciate that.
Yes.
But what I want to do is go back to the letter in 52, volume 5. I wanted, Amy, you wrote this on advice. I'm not expecting you to have done the research yourself.
But I did so.
My two, and this question I've been asked to ask you, is that reference at the end of that first paragraph, the occurrences of sporadic Cryptococcus with specific cohorts on this campus are expected, although occur infrequently. It's not really expected for renal patients, is it?
No, and it should have been clarified. And of course, in hindsight, I would rewrite this letter in many different ways now. But to be very, very specific in terms of what is expected, I think it could have been much clearer.
I mean, given what I'm about to turn to, and given how these cases came to the attention of RHI, this conversation was always going to happen, wasn't it? I was always going to ask you about this letter at some point in the autumn.
But I suppose that's what I would say is, even through this period, I'm learning quite rapidly of the significant level of issue.
Right.
And I'm learning more about what the specific issues have been, why they have been reported, why they have not been reported, how we would consider this different patient cohorts, the level of incidence, etc., etc. Right.
To go back to your paragraph we looked at before, we are keen to ensure, the fourth paragraph.
Yes.
This delay is the delay since the 20th of August, not the earlier delays.
I'm sorry.
So you in the fourth paragraph, we discussed how you wanted to involve the patient's clinical teams. This is about any delay since the 20th of July, not the earlier delay we're talking about.
This isn't, no, that's not what I meant by this.
Right, okay, what did you mean by it?
What I meant by that was we were keen, and historically that was the delay. So actually I think more correctly I could have said I'm sorry for the lack of timely response.
Is that the earlier one in the year?
Yes,
right.
to the information that was sent in July. We had wanted to ensure that X, Y and Z. So it's not looking for, because actually, as we will come on to in due course, within 9 working days of this, you can see, and we'll come to that, the number of actions that take place in order to expedite this. So I'm not actually saying here there's going to be another delay.
No, I think you've misunderstood me.
I'm sorry.
This paragraph I read as an apology for a delay.
Yes.
And I wanted to understand whether it's an apology for any delay that occurred between November of 24 and July, or any delay that occurred between 20th of July and now, 26th of August.
So no, I didn't mean the second part,
You meant the
because
first
I
part.
didn't, I meant the first part. And I'm also trying to say we will now expedite, and I'm sorry for any delay now, but we will expedite the information now. I actually hadn't expected, when I was told in the 20th of July, I thought we had I thought the information had been sent. So I wasn't expecting another,
So you weren't expecting a RHI to look at it and then have more questions?
or I was expecting to have been told there are more questions and we need to respond to this in a timely way. When the letter of the 20th arrives, I'm surprised, because I thought we had responded to it after Dr Davidson's intervention on the 20th of July. Sorry, am I answering your question?
No, you are. I'm just trying to make sure I ask my questions. One of the things that arises is the question of Caldecott approval. Now, it appears in an email exchange, bundle 52, volume 4, pages 80 to 81, I hope. Yes. And if we step onwards, yes. So one of the ICDs writes internally, I think, in the board, referencing the need for Caldecott approval. So is it your understanding that these concerns, the ones expressed in this email, arise as part of a process that also includes discussion with the clinicians who are treating the patients?
This is part of the, yes.
So that we have the whole exchange.
This historical part,
the historical
yes.
exchange
Yes.
is taking part as part of a discussion with clinicians who treated the patients and microbiologists who examined
Yes.
the samples.
And the reason specifically, and I'm sure that's clear in the evidence, but what was shared with me is because of the nature of the condition of these patients, it was very sensitive, because some of the patients may have had, for example, HIV or have had another disorder. So that's what I'm being told is some of the concerns about the sensitive nature. I don't know what the sensitive nature is, but it's being explained to me as such now.
Let's go back to the letter.
Historical piece, but I don't think it's, can I just reiterate again, I think these should have been resolved quickly.
Well, the one thing that occurs to me is that at one level, that's an obvious point. It will be sensitive because these are unusual cases, because we in the inquiry have had to deal with evidence around other Cryptococcus cases and find a way of discussing them in public, which has been hard.
Indeed.
So I understand that, but equally...
we should have found a way to resolve this. Right. We should have, no, there's no question.
If we go back to the letter on the next page, you mention in May 2025, the GGC infection prevention control doctors reviewed in depth each of the cases of suspected or confirmed Cryptococcus 2024. They didn't identify a cluster and respectfully asked the information provided the Scottish Government by our high colleagues be shared with the IPCT in GGC to ensure that any relevant information can be included in the review of these cases. Now, we later discover that all the information RHI had came from GGC.
Yes.
What were you being told about what information they might have had? Because you're obviously asking for information here, and presumably someone has said to you, you really need to ask the information.
Yeah, so at this point, sorry, I'm not sure I'm understanding your question, at which point you're speaking
So
about.
you're writing this letter on the 26th of August.
Yes.
And I read the second half of this paragraph as containing within it a request from RHI to get from RHI information that they have given to the Scottish Government.
Yes.
And I want to just understand why someone asked you to make that request, given that we later learn that all the information RHI had came in July from GGC.
Yes, I understand. So the first point around that is in response to Caroline Lamb's third point in her first three.
Well, we can jump back at that just to make sure we're looking at the right thing. So bundled 52, volume 5, document 31, page 144, I think. 145.
So in the first three bullet, it's the next page.
There we are.
In those first, she's asking for immediate confirmation that they're aligned. So I'm saying in this space that it has been confirmed to me that the local team have looked in May again to make sure there's not a cluster. So that's what I'm responding to.
I get that bit, yeah.
The second part that you're raising around is that the infection control team are basically saying, if RHI are now looking at this information and they have a different opinion and they have concerns that we should have reported something that we didn't, Glasgow is asking to understand that information.
Right, let's go back to the other letter. Yeah, we are. So again, just thinking about the chronology here. So the 4 cases that I put to Dr. Mumford and Miss Dempster on, I think, the 14th, it might have been the 13th, 14th of November last year, were confirmed by a Section 21 request to the board some weeks before. And we asked a series of questions, we received a series of answers, we then constructed a document which we put into the inquiry papers, which removed a lot of information. It didn't, for example, include the fact they were renal patients, because we felt we couldn't reveal too much information about individual cases. And we only asked the question of our experts around the question of reporting. We didn't ask them, is this a cluster? So that was November. And the health board provided an explanation about why it hadn't been reported to this inquiry in November, which is in a bundle. And so I'm wondering why it took from November to May for an in-depth review to take place of these cases.
So there wasn't, it's not that it took until May. My understanding is that an in-depth review took place in November. And then there's a refresh look at it in May again to make sure that there isn't something that has been missed. They consider each of the different elements in terms of criteria for onward reporting. But I think we would now say there's much debate within all of this and we need to discuss this as we go forward. But that's what that is saying is in November we look at it, the SBAR that we'll come back to in the previous paragraphs that is produced in November does look at that, and then they're looking at it again in May.
So we just go back to the next page, previous page 146. So at the second last page, paragraph of page 146,
yes,
there's a reassurance was sought by your predecessor and the chair, and that's when the SBAR is produced.
Yes.
And then in May, there's a fresh exercise or review.
They review again. They refresh and look again.
Let's think about the SBAR.
Yes.
So it's on page 148. Now, you're obviously not the author, and it was produced before you arrived.
Yes.
It was sent to your predecessor.
Yes.
Now, my first question, given, would you accept it's a little bit, its phraseology is not necessarily diplomatic.
No, and its tone isn't right.
Yeah, so why did you send it to the DG?
So if we look back to the letter, if I may, I do note it
Go back to the letter to 1446.
I know that it is historical information. One of the issues that's raised is that Glasgow isn't transparent in sharing information. I wanted to be fully transparent. I didn't want to redact a document that had been produced for a chief executive back in November. It was a clearly time-stamped piece. It was written for a purpose. The purpose was clear and it was sent at that time. What I regret in hindsight is I should have put an additional sentence into this piece to say, I do not support the tone or the content of this, and we're exploring this as part of our internal work. So there is a piece that could have added to that element, but it's not me endorsing it.
Yes, because when this document came to the Hinton inquiry, simply because of the multiple organisations it went to, given who it's copied to, we didn't see the context. And perhaps that sentence might have been helpful.
Indeed, and I absolutely, and that's why I put it forward to you now. However, what I would say is that there were conversations going on around these letters at that same time. And I could have made that clearer for sure in this letter. But I did want to, the purpose of sharing it in that regard was to show a historical document factually without or with complete transparency.
So the next question is, and you may not know the answer to this, but I suspect from your investigation you hopefully might. I get the impression from the way this is written, but I may be wrong, that the raising of these issues in the inquiry was to some extent news to your predecessor and the chair, which is why they asked for the S-bar to be prepared. Have I misinterpreted, or can you not help me?
I couldn't comment specifically on that. I can understand the assumption, but I can't specifically comment.
Let's go back to the S-bar. So let's just check a few things. Until we led evidence about the 4 of the cases, there are 7, I think, in total.
There's 7, yes.
Yes, the first one, 2020, we had led evidence on early in the inquiry, and it had been considered by Mr. Bennett, our expert on ventilation, in his attempt to understand the Cryptococcus cases.
Yes.
Because it happened during the period of the expert subgroup work, but wasn't mentioned in it. And so we explored that. And the later 4 we mentioned, we didn't pick up the other 3, but when those 4 were mentioned, they hadn't been reported to RHI, had they, at the point we mentioned them in November?
No.
No. And they hadn't been brought to the attention of the board, corporate clinical care and governance either.
No, because the local process is saying that they believe that they have assessed it not to be, and our local experts are saying that they do not believe this is an issue.
Which was my third question. Right. Do you have any concerns about that fact, that the local processes didn't draw them to the attention of the board's governance structures until the inquiry brought them in a governance sense?
I mean, I think you'll see from the actions that I've taken that I clearly, first of all, have to be concerned with this matter. We need to find a resolution. They are our experts, and the people who work in our organisation today are considered highly experienced experts. Their decision making is being challenged, and they are being asked numerous times to reevaluate this information. But I think, as a high level point rather than a specific response to your specific question, the tension in the relationship between NHS GGC infection control team and RHI definitely leads me to a place of concern and a place that we need to take action in order to resolve. It has been raised before. How would you know? RHI have said the points on a number of occasions, I understand, in this inquiry. We don't know what we don't know. So you would hope that how they know comes about from a number of different opportunities. It's been addressed that actually potentially a recommendation out of this inquiry might be the strengthening of national surveillance through all information electronically flowing up. I think we would all endorse that as an excellent way forward. That would let them do that high level surveillance. The second element then is having informal, trusted conversations locally between local teams and RHI when there are questions of dispute, or not dispute, when there are issues where people are not sure.
Professor,
Sorry?
this is very fluent. I'm finding it a little bit difficult certainly to note. And I just feel I may be losing some of the content of what you're saying by its very fluency, if I might put that point, or to be maybe a little bit more blunt. If you could maybe give evidence a little more slowly, I'll find it easier to follow.
Yes, I think what I might suggest is, we're coming up to the lunch break, and I think there's another point I need to put to you. And then I think I might revisit what you think about this whole experience at the end of this letter after lunch. But just ask you a couple of preliminary questions now, because otherwise there's a risk we keep going around in a circle where, for the reasons you've explained, you express some misgivings and concerns, you talk about what might happen in the future, and I'm going to come back to that. So what I might suggest is let's move on to a couple of
Yes.
questions and then we'll return to it. So I have been asked to put some content of the S-bar to you. And given what you said, I may already know your answer. Go to page 150. It's in the assessment section, the second paragraph. Oh, I take it you've read this.
Yes.
Do you accept that the allegations made here are rather serious?
Yes. And I don't think the tone or indeed the nature of them should have been articulated, certainly not in a formal S-bar. I think they raise a number of concerning points. Yes.
Did you make any attempt to investigate whether there's any merit in these?
Yes, and I think what is helpful in hopefully trying to be succinct with Lord Brodie's comments, it would be helpful if I also have the opportunity to step forward into what we have done to try to address these points, and
going
we
to
may
do that,
be able
but-
to step back.
But just looking at this document,
Yes,
it makes reference to statements by the whistleblowers, our high colleagues and experts. Now, I know what the statements made by experts are
Yes.
because they were here.
yes,
And I've asked our high,
yes,
well, in the form of Miss Emery, Dr. Miss Emery, what she thinks about that. What I want to put to you is that there has been no evidence in this inquiry by any of the whistleblowers or Dr. Inkster, who is not a whistleblower in this context, in the form of statements or evidence about the 4 Cryptococcus cases. For the very simple reason, I haven't permitted it to happen.
yes.
So why is that there?
So that's written in November, and I can't comment on why someone put it in the statement. I think what it underlines, though, is that there is a loss of trust in the relationship between NHS, GGC, Infection Control Team and RHI. Whether it is founded or not, I think is most definitely questionable, and I would not endorse these statements. However, there is a loss of trust. I'm sure the inquiry has explored these elements, but it is a very complex landscape, and I'm trying to be very sensitive in what I say because I recognise we have experts in different parts of our system who are experts, and they have had different professional opinions expressed through this period of time. Whistleblowing now has standards, but actually we need to be very thoughtful about when whistleblowing is raised, that we listen to people, and I'm sure we'll come back to that we listen to people. It makes their statements neither wrong nor right that they are whistleblowers, but it's within a context. And some of those individuals who have raised issues previously work in NHS GGC, now work in RHI. These are complex relationships. I'm not saying that this is the exact reason why people wrote this. I can't confirm. I wasn't the author. I do not condone it. However, I do think we need to recognise both the current state of the loss of trust in the working relationships, whether they are real or perceived. And I think what we need to be demonstrating as a system is as we go forward that we have systems, processes, and we have methodology that helps to rebuild those relationships.
I think in the few minutes before the lunch break, I should ask you this question. So I'll put something to you, because obviously this inquiry has been investigating to some extent and has noticed some tensions between RHI and the GGC IPC team, not least around the removal of Dr. Inkster as chair of the IMT in 23rd of August 2019, and that meeting and the subsequent doubling up of RHI nurses at IMTs. I'm assuming you know what you've found out about all
I
that.
know high level about all of these elements, although obviously I wasn't involved.
And I just wondered this question. If we accept as a assumption for the purpose of this question that there was a point in August, September, maybe October 2019 when relations between RHI teams and some of GGC's IPC professionals deteriorated. Now, that may not be the word you want to use, but in broad terms, is that broadly what your understanding is to some degree? That
I
there's a
think there's
moment
tension
there's a
and
tension of
anxiety.
inflection.
There is anxiety. I
Yeah.
think it's worth us noting. It's anxiety. It's anxiety about people's professional opinion and standing.
Yes, and so this is on both sides.
My perception,
Yeah.
yes.
But the point I'm trying to put to you is that that period of time, August, September, from the point of view of RHI and some of the IPC professionals in GGC, and that deterioration, it's a point of inflection. The deterioration gets worse. The anxiety gets worse at that moment in time. To some extent, would you accept that's your understanding as well?
That is my understanding,
right.
yes. And I think it goes beyond, I think there is also looking beyond the teams directly to look for help to resolve.
Yeah. I'm going to put to you something that's occurred to me. And of course, it's not a concluded view. I have to write submissions by the 21st of November, and I'm thinking about it all the time. Could it be that one of the reasons, that some of the reasons for this inflection point, firstly, might include the difficult issues that were being discussed in 2019? Was that possible? It's a much tenser period. There's lots going on.
I think that's a hypothesis that I can't say yes or no. I can understand the rationale.
But the other one might be that, could it be that actually part of the reason for this, from RHI's perspective, for this concern, is an observation of what they see as the response to Dr. Inkster from within GGC? So that, for better or worse, she is removed. And RHI staff see that and take it as a less than positive step. And that's part of the instigation of that inflection point.
I think, not being there at the time, I wouldn't want to comment to that specific. I think I've seen a number of very complex issues of people, and I think this is far, far deeper and wider spread than one or two individuals, because this is about professional opinion and professional standing. And so I think within the team, people are constantly, and I would say that from all of the difficult elements that I have read and heard, I do think at all points people are maintaining their commitment and indeed their responsibility to do the best for the people that we serve. I think that is their motivation at all point. I don't think this is about a breakdown in relationships, which is around getting at one person or another. I think people are trying in a difficult, very complex landscape to hold to what they think is the right thing for patient care and to report in what they believe is an honest and balanced way. I'm not an expert to be able to comment, and I know many other experts have.
Before the lunch break, to what extent, what's your understanding of how long in time there has been a perception of less than positive relationships within the IPC microbiology community in GGC? And just in very broad terms, is this something that starts then or goes a long way back in the past?
I don't think it's just about GGC infection control team and RHI. I think this is about a complex landscape. If you think about it in career positive terms, and the fact I bring us back, people, we all come to serve people, to do the best we can for people. A new building is coming and there is much hope. And then as this new building comes to fruition, there are issues, one after another, and infection control is raised in there. We know that there were building design and construction issues, so people are constantly concerned about this to make sure they are discharging their duty. So I don't think it is as simplistic as just GGC, RHI. I think this is a period of time from 2015 onward where people within their professional sphere of responsibility are in a heightened state of anxiety in terms of wanting to be assured and to give assurance that things are okay. And I think that starts to create a different landscape where you need to make sure people feel that they're being listened to, that they're empowered to raise things within their team, between colleagues, and indeed with more senior colleagues. It's a very, very complex issue. So I don't think it's as black and white as there is a point at which our high-end GGC, and I can't comment on that specific date, having not been part of that journey, but I do think the complexities
But you
that
see
are
it as
there.
a complex thing that goes back in time to the new hospital.
Yes, and as differences of opinion begin to form within the teams, there is challenge between individuals. Whistleblowing is part of that, but there are, on a regular basis, there are differences of opinions beginning. And I know some statements have been put into the inquiry, but that is what I'm seeing. It's a difficult space to work in.
Let's pick that up again after the
Yes.
lunch break. I'll try and, I think you've answered some of my questions, or I haven't asked yet. So I'll need to reflect on that. Well, this might be an appropriate time to break for lunch.
We'll take an hour for lunch, Professor. So could you be back for 2 o'clock?
Yes, thank you.
Thank you.
Is that